We are in a perfect segue to the next segment of our afternoon session, which is a hot topic for many patients about optimal sequencing, which order to do treatments in that may not preclude another treatment, how to make that decision. And here to help us with that is Dr. Aric Lee, who many of you know is co-director of the Neuroendocrine Institute at Rocky Mountain Cancer Centers in Denver, Colorado, just a short flight from here. He is a surgeon specializing in net tumors and related diseases. He was educated at Harvard and Columbia University. So impressive.
Very expensive.
And he also trained in Sweden under Dr. Oberg, and is now here to join us. He is the first person to have the Gallium-68 scan in the United States when he was at Vanderbilt University, and also is the founder of the Healing Net Foundation. We have some brochures outside. This is a really important organization that is helping patients bring information to their regional doctors, and we can learn more about that later, but please see the Healing Net Foundation brochures outside. Please welcome Dr. Aric Lee.
Thanks, Yvonne. I should introduce her to my mother. I think they both like each other. Okay, so my job today is to tell you all about the sequencing of it, right? And because you've seen a whole bunch of things. So sequencing of treatments for neuroendocrine tumors. So just to start you off, so I live in Denver, Colorado. It's known for snow. It's known for beautiful mountains. And it's known for great dinners. Anyway, so we kind of created a little thing called the Neuroendocrine Institute, you know, just because we have a multidisciplinary team, that much as you heard previously. So, but we invite you all to come to our clinic. It's really quite wonderful. Here's my clinic. It's right there. See it? Right there. You have to get to it by airplane. This is one of my patients. His name is James B. Preserve his identity. And that's a bag full of sandostatin that he's carrying there. So anyway, it would be great for you to come. It's not that far from here. It's really fun. So sequencing. Sequencing, is it really that important? Let me just illustrate for you. This is the problem. So you have surgery, right? You've got somatostatin analogs. You've got this radioembolization thing. You've got PRRT now, which is very exciting. You've got Afinitor. You've got Temodar. You have more surgery. Chemotherapy, perhaps. Sutent. Biologics. Bland embolization. Immunotherapy. In no particular order, chemoembolization. And I'll bet it feels like this sometimes, right? I mean, I didn't make the slide to show off my PowerPoint skills, which are actually very awesome. I did this because this is kind of how it feels like for you, right? And I'll bet it's kind of how it feels like for your local doc. And I'll bet sometimes this is kind of how it feels even for your neuroendocrine expert. The neat thing about it is that you have a lot of options, right? Which is great. But the problem is, what do you choose and when do you choose it and who's the right person to do it for? And then when do you do it relative to something else, right? So, you know, we're a whole panel of neuroendocrine people. When I see a patient, I don't just think about what to do today. I think about what I need to do next year and the year after that and maybe 4 years down the road and maybe 10 years afterwards, right? This is how I think. And then after a while, though, it just kind of looks like this. It kind of looks like a big old blob of things together. So this is why I often stress, so if anyone's does Facebook, you should Facebook friend me. But yeah, right, I know, social media. But the reason is because the reason you want to see a neuroendocrine expert is because we can help you figure these things out, okay? And so just as we heard before, how do you decide on treatment? Well, always, 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 you should always weigh the risks and the benefits, right? It's in a way, it's like every decision you ever make. But really you want to think, well, what is your goal, right? What are you trying to achieve, right? Are you trying to get your symptoms under control, which is actually really important, right? Quality of life should always be your #1 thing. You can never control your quantity of life, right? Any of us could go outside and, the airplane could have some kind of problem. But symptom control and quality of life is extremely important. Well, then, are you trying to remove your tumors? You're trying to get them all out? That's a very worthy and honorable goal. Do you want to shrink your tumors, right? Then you should choose the right therapy, depending on which ones have the highest probability of shrinking it for you. Or are you trying to prevent complications, right? So we talk about these fancy things with tumors, but you don't always realize how people die from neuroendocrine. A lot of people die from the complications of these tumors rather than just the tumors themselves. Or you're just trying to stabilize disease, right? So you have to think very hard about what you're trying to do and weigh what the side effects and the risks are and what you're trying to achieve. So the question now is, what do I have in the toolbox, right? So there are actually a whole bunch of things, and this is in no particular order, but you can always do surgery, right? So when you whip out that scalpel, you want to say, okay, I think I have these particular goals. I want to make the tumors disappear, right? We talk about response rates and stuff. You know what's a good response rate? When you take a tumor out and throw it in the garbage can. That's a good response rate. Maybe you want to prevent complications, right? I'll show you some pictures in a second, but people get bowel obstructions all the time, right? I'm sure there are several people in this room who feel like their guts are twisted up in a knot all the time. We don't think about this, but sometimes even if you have a pancreatic tumor, you can clot off the arteries and veins to your pancreas and cause all kinds of problems and cause bleeding. Or are you just trying to control symptoms, right? So sometimes you have a lot of flushing and diarrhea, and we talk about these magical medicines that we give, the somatostatin analogs and these serotonin inhibitors. You know what works really well? When you cut the tumors out, you throw them in the garbage can. It's hard for the tumors to secrete hormones to bother you in the bucket. But of course there are risks, right? So there are operative risks. You have to weigh those things, right? It's certainly no walk in the park. But certainly in good hands, these operations are done extremely safely. Look, here's a bunch of tumors I just chucked out of someone. Got to the point, I used to put them all in little cups, and my pathologist says, please send me 50 cups. So now I just stick them in a bowl. But that's it. They can't hurt the patient anymore, right? Here's an example of a patient who had a lot of abdominal pain. See, look, her intestines were literally knotted up, and she saw multiple doctors, and they said this can't be removed, so we removed it. Okay, so surgery is an excellent option, right? Okay, how about somatostatin analog? Excellent tool, miracle drug as far as I'm concerned, maybe next to insulin alone. But really, your goals are probably to control your symptoms and tumor control. Right? So it's great. And the risks are relatively mild. I mean, a little monthly injection, maybe a little queasiness here and there, but it is a miracle drug. I love it, both versions of it. So now how about this liver-directed therapy, right? We heard about that. Well, the goals most of the time are just to, maybe get some symptoms control. So the study that we heard about before by Dr. Andy Kennedy showed that you had excellent symptom control and some tumor shrinkage and stabilization up to about a year, but it was only to about a year or so. So that certainly might be something you want to do. But at the same time, the risks are real. We heard about this radiation-induced liver disease, which is a real problem in our neuroendocrine patients. It's one thing if you have really nasty colorectal cancer and you get treated and you expect to only live 3 or 4 years. But if I expect you to live 8, 10, 12, 15 years, then I have to be able to think about the risks, and you see more of these problems as the patients live longer. As we had mentioned before, you might lose your blood supply to the liver. So if you have a chemoembolization, a bland embolization, when you now cut off the route to your tumor, and then you suddenly cannot deliver radiation to there anymore. So you have to think about that. And really there are a limited number of treatments. It's very similar to the PRRT story. You can only give it so many times before you burn the liver out. So these are the things to consider. How about the PRRT? Super exciting and wonderful, right? But at the same time, your goal is kind of the symptom control and hopefully tumor stabilization. And the risks are, while relatively well tolerated, which is terrific, are real. And actually the major one is not so much the kidney thing, it's this bone marrow toxicity, right? So we have certainly seen people who've had decreased bone marrow production for permanent problems. And even in some cases you develop some leukemias, relatively unusual, but those things are something to watch out for. And then again, you only have probably a limited number of treatments. My mentor from Sweden, his name is Dr. Oberg, you know, he's given treatments in some patients to 11 or 12 times, and Dr. Baum in Germany has done the same type of thing, but it's relatively limited because of the amount of radiation the rest of your body can tolerate. So it's something that you have to think about very carefully, and so you can see why you have only a limited number of tools. How about our targeted therapies, right? Our Afinitor everolimus or Sutent sunitinib. You know, I'm very happy to have them as tools. But really, for those two, your only goal is tumor stabilization, right? You want to just keep those things frozen, which is a good thing. Every day that a tumor is not bothering you and is stable is another day that you're doing well, right? However, there are real risks to them, right? So for the Afinitor, you know, you can have some fatigue, some mouth sores and things like that, even some pneumonitis in rare cases. The Sutent can cause a lot of hypertension, can cause really bad fatigue, asthenia. So you watch out for that. And of course, you saw the curves, you know, they all kind of come down, so there's always just that risk of treatment failure, right? So at some point, it's just going to poop out and not be persistent enough. So that's what you're trying, but you're trying to achieve tumor stabilization, and I'm okay with that. All right, now how about chemotherapy? Chemotherapy. Well, in some cases, it works really great. For those very high-grade tumors, when the Ki-67 is, say, above 50%, right, they may actually work really well. You may get some shrinkage as well, and you might get tumor stabilization, especially with this new combination based on Temodar. But the risks are real, right? So there are side effects, and some of them are permanent. I mean, if anyone who's taken a whole lot of platinum in their lives, they may not be able to feel in their hands and their feet anymore from that neuropathy. And a lot of people have a lot of long-term consequences from the chemotherapy. So it's something to really weigh and watch out for. It's probably not fair that I put a poison sign up there, right? There, that's much better. Okay, so really the art of neuroendocrine is not what to do, it's when to do it, right? That's the thing, it's when to do it. And this is a very famous Chinese saying, right, Dr. Yu? Very famous. So if you're a regular kind of run-of-the-mill general oncologist out in the road, you need guidance with neuroendocrine, right? And so the place that everyone goes is something called the NCCN. It's the kind of the gurus, the ivory tower people get together and they talk about how to treat these things. And if you look up neuroendocrine, this is what you see, right? It's not so simple. There's a lot of information in there and there are a lot of breakpoints and it's hard to figure out because each and every one of you is so very different, right? But if you look at even one of these panels, right, and this is one for GI tract, lung, and thymus, so pretty standard stuff that we see a lot. It says here, well, for this and this, you can do this and this. And then look at the last part on the right. Well, if you have progressive disease, sure, you can give octreotide or lanreotide. Oh, sure, you can embolize it. Oh, sure, you can do surgery. Yeah, you might want to give everolimus. Heck, you can even give interferon. Or maybe you can give cytotoxic chemotherapy. So which one would you give for you? Just because you can doesn't mean you should, right? And so this is where it becomes very complicated. And this is literally the guideline that the ivory tower people are giving you. And it's good. Don't get me wrong. This is actually a wonderful document because it actually gives the oncologist more leeway. But neuroendocrine disease is kind of so specialized, and from person to person, you know, you really want to talk to someone who specializes in it so that they can choose the right therapy with the right information to give you the greatest benefit with the least amount of risk. And this is the issue. Each individual is different. So, you know, the mascot for neuroendocrine is zebra. You know why it's zebra? Because in medical school we're taught, if you hear hooves, think horses, not zebras, right? So if someone has a cough, you should think, oh, pneumonia, bronchitis. You shouldn't immediately think, oh, this person has miliary tuberculosis, right? Yeah, it could be. But every now and then you're flushing. Every now and then you're abdominal pain. Every now and then your diarrhea is caused by something really weird and funky, like a neuroendocrine tumor, and then you're the zebra. But if you look at the zebra, the analogy actually goes much farther, because all the zebra stripes are different, right? But in a way, we're all kind of the same, because we all love our children like that zebra loves her baby, and we all drink from water. So there's something still similar that binds all of us. So despite the fact you're very different, you can all sit in this room and still get a lot of information out of this. Okay, so these are some of my principles of sequencing. So I think, this is how I think philosophically. What will kill the person first? I know you're laughing, but it's very true. I mean, I've got people who have been put on, who were told to go on hospice. However, they had a very repairable issue. They had something that's very fixable. And so that's what I figure out. What is going to hurt you? All right. So, and then can I fix that problem? Right. That's the first thing I think about. And then I think, well, what will hurt the person in the future? Right. So if you have tangled bowels, I promise you, you'll get a small bowel obstruction. And there's a fair chance you could suffer badly from it or die from it. And then again, how do I prevent that problem? Can I remove it? Do we treat it with PRRT? Do we shrink it down with some kind of chemotherapy? How will my therapy hurt the patient? Right? That's really important, because if I have some therapy and I have to remove all of their guts, that is not compatible with life. How many times can I use my therapy? Right? We just learned about it with our PRRT, with our embolizations. If I use one, will I burn a bridge for another? And we'll talk about that in a second with the panel. And finally, can I work with someone with more knowledge on NETs to get the best outcome for my patient? Right? So when I don't know which chemo to give, I've done this before, right? I have called Dr. Kunz in the middle of her clinic saying, hey, do I have to do something? I've called Ed Wolin before and asked him how his clinical trials are doing. I've never called Dr. Yu before. Sorry, buddy, I'll start getting on you. But again, this is part of the teamwork of how we take care of people, all right? So, but if you really want to talk about therapy to therapy, right? So again, in no particular order, you should know, if I can cut it out, you should cut it out, all right? And then if you're not sure, you should ask someone if they can cut it out, right? And then the third therapy should be what? Cut it out. Excellent, excellent. Except that the third period is different. If you have terrible symptoms, use your somatostatin analog. Use that first. Get it going. Get your pain under control. Get your diarrhea under control. You can do those things. The risk is very low. If your disease is extremely aggressive with a high Ki-67, then give the chemo, by all means. If the disease is progressing and it's kind of in a mid-grade, maybe a targeted therapy is what you want to do. If the threat is the liver, use the liver-directed therapy. If it's gallium positive, consider PRRT. And finally, when you don't know, go back to number one and look it through the whole menu one more time and reevaluate every single time. Because if you, for example, like I said before, if you have a whole bunch of tumors and one of them is really misbehaved, maybe you just go and remove the thing. Maybe you don't have to switch a systemic therapy. Maybe just get it out and then everything else is stabilized. So you have to think about it as a multimodal, multidisciplinary kind of disease in order to get your best outcome. And you revisit them every single time. Okay, so this is my little team. It's actually really fun. That's me. Dr. Cohn is in the middle. He's my medical oncology colleague I work with. And Charlie Nutting is a superstar interventional radiologist I work with. He's done, I think, like over 1,500 Y90s. So there's something to say about experience. This is our office. That's my dog. He's so handsome. This is our team. If anyone's ever called, you may have talked to Donnie or Pam. They're really great. And this is just kind of a fun picture. So everyone heard that gallium was approved a couple weeks ago. This was actually a meeting a couple years ago. It was the first meeting we had at the FDA to talk about the approval of gallium. So since I did the very first one in 2010 to now, it's been quite a tour de force, and it's been a very gratifying journey. Yeah, you should clap, clap, clap. Yeah, gallium is awesome. I do want to touch just for one more second on something that we have started called the Healing Net Foundation. There are a lot of great foundations represented here in this room. You know, certainly Net RF is our research workhorse. But the Healing Net Foundation really believes very strongly, because about 90% of all cancer care is actually given in the community. And a lot of people don't know about neuroendocrine, so we're trying our best to get out there. So go to the webpage, you can get some information. This year, in February of 2016, I actually convened 33 of the most famous neuroendocrine docs in the world in Beaver Creek, and we hashed out and debated a lot of issues. It was a really, really neat and fun meeting, and I learned a lot. So we're doing some interesting things. If anyone's interested, we actually wrote a little primer for neuroendocrine. You can grab, I think Giovanna has a bunch of copies, so grab a copy or you can download it from the website, take it to your doc, read it. It's a very 10 pages, it's very, very digestible. We wrote it so it's very easy for your doc to understand, but it may give you a little bit of a leg up to understand why we do the things we do and what the information means. And this was just a really neat video that we did, a public service announcement. This is a fellow named Trey Anastasio. He is the lead singer of a band called Fish. You heard of P-H-I-S-H, hence the entertainment. But watch.
Hi, this is Trey Anastasio. Cancer is an insidious disease that can strike anyone at any time. I know firsthand because I lost my sister Christy to neuroendocrine cancer 6 years ago. More than 1,500 people are diagnosed annually with some form of neuroendocrine cancer in the U.S. alone. One of the organizations I support is the HealingNet Foundation. HealingNet works tirelessly to support the needs of those afflicted with neuroendocrine cancers and to provide services to those in the medical community who diagnose and treat that class of cancer illnesses. November 10th is World Neuroendocrine Cancer Awareness Day. Please remember my sister, my family, and others afflicted with this misunderstood disease on that day. And please do all you can to support cancer research and HealingNet Foundation in your community. Together, we can make a difference.
Yeah. Good job, Giovanna. Thanks for the music. But it's a mission, and the sad thing about Trey is he just lost one of his other best friends, his manager, also to neuroendocrine cancer. Yeah, so he's lost two now, people very close to him. So he's been very supportive and just a wonderful figure. So if you can, do what you can. We're all warriors in this crusade. We're all in this together, so we can do this. And of course, it takes a whole bunch of people to do this. So, okay, so that's my little spiel. Now, I think there are a couple things that we should just hammer out, and when it comes to sequencing, and we should discuss this. And these are things that come up all the time, and certainly I need people smarter than me to figure this thing out. So let's start with a medical oncologist, and let's ask them. We have a bunch of drugs, right? There's Temodar, there's Sutent, there's Afinitor, there's probably other clinical trials. So how do you choose which one you start with, Dr. Kunz?
All right, not an easy question. So I think, it really depends on a number of things. It depends on, we've talked about this before, where did the tumor start? Is it a pancreatic net, a lung net, or a small bowel net? What's the grade of the tumor? Is it more slow growing or more fast growing? Do you have symptoms from that disease? Are you flushing? Do you have symptoms from tumor pain? So all those things factor into my decision making. So if someone is fairly asymptomatic but may have slowly progressive but pretty low volume disease, I might start with a somatostatin analog.
Well, so skip the analogs. That's Dr. Yu's job, really. But just of those three, for example, or Folfox, or Cisotopicide, or something like that. How would you choose?
From the chemotherapies?
Yeah, or the target therapies.
So say we've used the somatostatin analog already,
right.
So which would we go to next? So I think that also depends on those same factors. So if I really need to shrink the cancer because somebody's having symptoms from their cancer, for pancreatic nets in particular, we might consider chemotherapy, temozolomide, and capecitabine. And I didn't like the skull, so not all.
But I put glasses on it. Yeah, clearly.
Yeah. So I tell my patients, not all chemo and oncologists are all that bad. So, so actually, Temodar and Xeloda are actually, in some cases, better tolerated than some of our biologics, like sunitinib, Sutent, or everolimus Afinitor. But if you need to shrink a cancer, the chemotherapy often does a better job. PRRT, actually, when we have that available to us, also shrinks. The other biologics, Sutent and Afinitor, tend to freeze things, as Dr. Liu said, and hold things steady, which is not a bad thing, but if you're already having symptoms from your disease, that might not be the best thing to start with.
So Dr. Hendifar, so if I had just to choose between this sunitinib and the everolimus, how would you choose?
Well, then that probably means you have a pancreatic neuroendocrine tumor, and usually we would choose between the two based on the morbidities of the patient, meaning what are the other medical issues that the patient
just turn it. I think it's pointing the speaker. Yeah, turn that way. Yeah, and speak into it. Yeah.
Yeah. So if the patient has hypertension, history of stroke, DVT, PE, pulmonary embolus. So I'm using all these weird acronyms. But any of those things happen, then you would probably, favor everolimus over Sutent. So basically, we kind of try to base it on each particular patient, which one we would choose.
So Dr. Wolin, if you were to go even more high grade and you were choosing more kind of IV-based therapies, a carboplatin versus a cisplatin versus an irinotecan versus some other cytotoxic chemotherapy, how would you kind of choose and sequence those?
I think unless the patient's on a clinical trial and has true high-grade neuroendocrine cancer with a Ki-67 over 50 or 55%, my first choice would be a platinum drug, whether it's cisplatin or carboplatin with etoposide. I think if that either doesn't work or stops working, the best option is a clinical trial, hopefully one with immunotherapy in view of the very exciting results that Dr. Kunz is going to be talking to us about soon. With respect to carcinoid tumors, we don't really have this whole big list of drugs. You mentioned Sutent and all these things that are not approved for carcinoid tumors. For carcinoid tumors, the only approved treatments right now are everolimus and lanreotide, and everything else is still investigational. Hopefully we will have PRRT to add to that list by next year, but I would encourage people to enroll in good clinical trials whenever possible, because really there's a lot of very, very promising things right on the horizon right now. And we're really very limited for most kinds of neuroendocrine cancers. Pancreatic neuroendocrine tumors are uniquely responsive to a lot of things.
Yeah, I totally agree. I think that's good. You should always consider enrolling in a clinical trial after you've had surgery. So let's talk about the interventional radiologist. So how do you choose the embolization? You have all these tools. They're very expensive. Which one do you go with?
Well, that's a tough question to answer, and it's often very nuanced. As we mentioned before, if you do a bland embolization first and block the artery, you can no longer then go back and treat with radioembolization. So you always got to think about radioembolization first. When you consider someone for radioembolization, you think about the hypervascularity of the tumor. You think about the tumor burden within the liver. I think typically when patients have a really high tumor burden in the liver, greater than 75% probably, or around there, maybe even greater than 60%, you start to think about bland embolization, at least I do and Dr. Friedman, because when you have a high volume of tumor, bland embolization may probably does a better job, because the radioembolization particles, you need a lot of them to treat a large volume of tumor. So individual particles give off the radiation, and if you have a big tumor burden, you might not have enough particles. The other thing that you've got to think about with radioembolization is, you mentioned, and something that I think is very important that I've discussed with Dr. Hendifar and Dr. Nissen quite a bit, that for patients with neuroendocrine tumor who have a longer survival time compared to other types of cancers like colon cancer, you really have to worry about the effect of radioembolization on the liver over a long period of time. So that needs to be taken into consideration. And the other thing that you need to consider is the state of liver function when you're first evaluating the patient. For anybody who has any sort of liver dysfunction, we tend to shy away from radioembolization and would probably prefer bland embolization instead.
Right.
So.
Perfect. Good answer. So how about surgery? We saw a lot of gross pictures this morning about the liver. So when do you do interventional radiology and when do you do surgery to debulk the liver? Go ahead.
So me.
Yeah.
So in general with us, if you can cytoreduce someone to no disease or very little disease, that's the best option. When they present with regional disease, so a primary with nodal disease, and they've got a few liver metastases, and you can resect them all, I think that's the best way to go, and then treat them with sandostatin thereafter. If you have someone with numerous liver lesions, then really at that point we just address the primary, get rid of all the mesenteric disease, and then refer them to more liver-directed therapy.
Right, exactly. Ken, tell us, this is going to be a big issue for us because PRT will be here soon. When do you choose BRT and when do you go liver-directed therapy?
So the easy part is, if the disease is disseminated, then it's of course PRT, which means a lot of disease outside of the liver. If it's liver predominant, or like you would say, it's the patient's dying most likely from the liver, and you cannot resect it, then it's something we discuss, and a decision we take actually also in agreement with our interventional radiologists. Key thing is I like the combination of both very often because, first of all, you can decrease the tumor burden by selective liver therapy, and then in the second part perform PRT. And I also agree, especially if the kind of embolization is not a radioembolization. Actually, we have very good experience in Europe doing the combination of both of them. But again,
PRT and radioembolization.
No I mean, normal embolization like TACE or whatsoever.
I'm sorry, okay.
Yeah, so
I'm
not
sorry. Non-radioembolization.
This, I agree with you, the RILD is some issue. And yeah, this is pretty much what we do.
Perfect. And finally, for our endocrinologist friend, you now have 2 long-term somatostatin analogs. Which do you choose?
Thank you for giving me this least controversial question. Yeah, I think they are equivalent, so that really the practical issue, which is mostly cost and convenience, determine which one to use.
Excellent. Well, that's it. That's the last slide. Thank you to the panel.